sensationnel.
So far, we've only dealt with the heart itself. Now it's time to look at the great vessels, and specifically the aorta.
When we are in our echo lab and we perform a transesophageal exam, we always look at the aorta. When we finish the exam, by retrieving the probe, we can really scan the vessel. Do you always do like this, Bruno?
And it's not so easy to perform such complete examination on the intensive care unit. Normally, we examine the aorta only in the patient that received an operation of it, or if we have a suspect of a new pathology on the aorta. But I would suggest for oral cardiac anesthesiologists to use the examination of the aorta in every case in the operating room.
And which views do you need to really scan the aorta?
We have at least 6 views to look for to watch the aorta. We know that we have to analyze the 3 different parts of the aorta: the ascending aorta, the aortic arch, and the descending aorta.
So let's go systematically and see also the anatomic correlation.
Let's see the aortic views. From 4-chamber views, middle esophageal 4-chamber views, you can change the image to the descending aorta short axis view, and it's very easy because you don't have to do nothing other than rotate the probe to the left.
It's really nice to see what happens in our echo image, so the probe turned to the aorta.
And you look to the left atria, because of, if you look at the left atria, the next cavity that we will see is exactly the aorta, the descending aorta. From the descending aorta short axis view, the long axis view is very easy. We have only to push the button and change the angle to 90 degrees.
Do you know, Bruno, what I like at this point is actually I like to optimize my image. Looking at depth, I would increase it to have a real focus on it, and then I would also move the focus and really place it near the vessel.
Yeah, this is a very nice idea. And then what is interesting with the descending aorta is that when I pull out the probe, I can scan the whole aorta till the aortic arch.
Can you see also the ascending aorta?
I can see the ascending aorta too, but we have to go on the 4-chamber view. It's much easier to get this image from the 4-chamber view because of the blind spots that are on the distal side of the ascending aorta. So what I do? I do nothing other than to get the 4-chamber view and then pull a little bit out the probe till I see the 5-chamber view. The aortic valve stay in the middle of the image, and then with a little bit of anteflexion, aorta anteflexion, always with A.
Double A.
You have to pull out the probe and you will see the aorta always in the middle. And when you are in this position, where you see the main pulmonary artery, the right pulmonary artery, and on the left side of the sector, the vena cava superior, in the middle of this image, you have the ascending aorta. Now, if you want to see the long axis view of the ascending aorta, you have only to push the button and to go from 0 degrees to 90 degrees. And now we have the ascending aorta in this image. It's very easy.
So thanks, Bruno. Just to sum up, what you need to scan the aorta during a transesophageal exam is you retrieve the probe, and then you can get the short axis and the long axis just by playing with the angle 0 degree, 90 degree. But wait, Bruno, we forgot to show the aortic arch.
Oh my God! Yeah?
Go.
You are right. So, how do we get the aortic arch? If we are on the descending aorta, we have to pull out the probe till from a circular cavity, we will see an elliptical cavity.
Yeah, this means we are turning into the arch from the descending.
Exactly. This is the easiest way to have the aortic arch on your screen. It's very easy, very fast, and especially for the diagnosis in patients with type A dissection, it's extremely useful. Don't forget, the aortic arch short axis view is with 0 degrees, but we can change with 90 degrees in the aortic arch short axis view, and the aortic arch short axis views show on the left, on the sector, an important vessel. This is the main pulmonary artery, and sometimes it's possible to see very well the aortic valve. And here it's possible to measure the gradients on the pulmonary valve.
So in summary, to study the aorta, you need several views. Here are the typical cut planes that I would use to assess the entire aorta, from the ascending part to the aortic arch to the descending thoracic aorta. Here are some examples of what you can find in the aorta. A huge plaque in the descending aorta, fibrous plaque, and if you look closely, you see a little bit of spontaneous contrast. A patient who has a rather normal aortic wall, maybe a little bit of atheromatosis here. A patient with dissection, look at this membrane here. This is the dissection. And a patient who has irregular plaques here in the descending aorta seen in a longitudinal view. What else? Well, sometimes you'll be surprised that you can find even very small little mobile structures on one of these plaques. And this is a beautiful example of how one can visualize that in a 3D image as well. Yeah, this is certainly something you don't want to have. Imagine this lodges and certainly would cause some form of embolism. So you see, the aorta is a very important part of transesophageal echocardiography, and as already mentioned, I would perform a view, or at least some views of the aorta in all patients. Rarely would we introduce the TE probe deeper into the stomach to perform so-called transgastric views, at least not in our patients. But this is more frequently done in patients who are under anesthesia and where the discomfort of this procedure does not really matter. And especially anesthesiologists love these views because they help us to look for left ventricular function. Let's see how we get there.
I think you already realized that transesophageal echocardiography is performed differently if we perform it in an echo lab or on the intensive care unit or the OR. But I would like to ask Bruno, what is the value of the transgastric view in his clinical scenarios in his patients?
Yeah, Thomas, for us it's very important, the all transgastric views. The first, because of the ventricular function determination for the right and left, and later we will see for the aortic valve too. So let's see how I can examine from.
How do we get such a view?
Yeah, let's see. I start with the 4-chamber view, as always, and I put the probe inside till the left ventricle looks like a circular structure.
Are you in the esophagus now with the probe, or where are you now?
I think at the moment I am at the beginning of the stomach, probably in the cardia too. I would like to put 1-2 centimeter inside the probe. And now it's very important. For the transgastric views, you need anteflexion because you are below the diaphragm and you want to see the heart. And if you want to see the heart, you need the anteflexion. It doesn't work without.
Okay, so what structures do we see here?
So now we are in the mid-papillary short axis view.
We've got the papillary muscles right here.
Exactly.
This is the left ventricle, round structure, right ventricle, and then we have different segments of the myocardium here. Do you want to explain maybe, Bruno?
Yeah. Do you know from nomenclature of the heart, the left ventricle is divided into 6 different walls. The anterior walls in our transgastric mid-papillary short axis view is not the closest point to the probe, but the most distant point on our circle.
Yeah, it's important, it's easy to remember because remember, you're looking from behind the heart. So this would be the esophagus. So the closest part must be
The closest part is for sure the inferior wall, and you see here very close to the septum. Yeah?
Right. This is the inferior wall, this is the septum.
Yeah.
Here we have the anterior wall. This would be the anterolateral wall, lateral wall, and this would be probably the inferior wall already here.
Yeah.
We chose a pathology for this demonstration to also highlight that it is important to look at this pathology in this short axis view. And Bruno, just give us the answer. What does this patient have? I think many of you have probably realized that something is wrong here.
Okay, we will see that all around the heart there is some fluids, and this is a typical image of a pericardial effusion. And probably you can see something more on the movement of the heart.
Yes, you will realize that the anterior wall is not moving. We have clearly a regional wall motion abnormality, and this must be coronary artery disease, it must be an anterior infarct. So let's study this anterior infarct, and while we do this, explain you which segments of the ventricle we see in this view.
Okay, we can see if I put the probe inside and I make a maximal anteflexion, we will get the fish mouth, and this is the basal segment of the left ventricle immediately below the mitral valve.
So it's the same if you perform a transthoracic echo. We're now right at the base of the heart. We have the mitral valve here, and we're just transecting right through the leaflets, and we have the anterior leaflet here and the posterior leaflet here. This would be the posterior medial commissure, and this would be the anterolateral commissure. So we can even distinguish the different portions of the mitral valve as well, and this must be the basal part of the ventricle. Again, here we see this wall motion abnormality right here in the anterior portions of it.
Exactly. The next image is, we have already seen the mid-papillary, and then it's possible to see the apical segment too, and we have to leave only the anteflexion, something more. Probably we put the probe something more inside, we reduce the anteflexion, and we see a very small circle. And this means that is the apical part of the left ventricle.
So there you see that the wall motion abnormality is encompassing the entire apex. This fits very nicely to an anterior infarct. So in summary, the transgastric view, the short axis view, gives you good information about left ventricle function. It allows you to look at regional wall motion abnormalities. You can see a pericardial effusion as we saw here. But there is one more additional great advantage of the transgastric views, but we'll show you this in a later demonstration.
Just to summarize, this is a typical transgastric short axis view, actually more at the level of the mitral valve, but still I think a good view to assess left ventricle function. I guess you all agree that function is normal and that there are no regional wall motion abnormalities. This is different in this example of a patient who has dilated cardiomyopathy. The ventricle is dilated and there is global left ventricle dysfunction. We're not done yet because Bruno still has an important view for you.
In most patients with aortic stenosis, you will not need TE. You can easily quantify it with transthoracic echo. But there sometimes are situations where TE is mandatory, where you have to use it. For example, in patients who have very poor image quality, or if you have patients on the intensive care unit who are anesthetized or intubated, there you have to use TE to quantify aortic stenosis. And there is a way of doing it, even though it's very difficult. Bruno, I think you can show us how to do it.
Yeah, Thomas, it's no problem. We will get all the images from transgastric view for the aortic valve. We can see the deep transgastric view is one of the most difficult to get in the transgastric section because of the most of people lose their orientation during the image representation. We have 3 important movements to perform to get this image. The first of them, starting with the transgastric mid-papillary short axis view, we leave the anteflexion. It's very important to leave the anteflexion because you cannot make damages in the stomach. Then, very slowly, you put the probe inside till you feel a resistance. That means the tip of the probe is on the body of the stomach. Then you can perform the anteflexion and the flexion to the left side. That means you have to turn the 2 wheels in the opposite direction.
So that means you have the probe in the stomach and you are now retroflecting it back towards the heart. Yeah, to the heart again.
Exactly.
So, and this is the motion you do, and the sideways motion is also important so that you don't diverge away from the apex, right?
Exactly, exactly. And that's why you use the left flexion. Sometimes you don't need at all the left flexion, but at the beginning it's very nice to use always for the first times. Then, as soon as you turn the 2 wheels, you can slowly pull out the probe till you see the deep transgastric view.
So I think this is a very nice view now. We have the aortic valve right here, the ascending aorta in the far field, and you will realize that the orientation to the ultrasound beam is very parallel. So this is exactly what we want. As a matter of fact, it looks something like, I would say, an apical 3-chamber view, or I would say a peristernal long axis view, which is somehow returned to 90 degrees. So it's a view we know already. This would be the left ventricle, this is the right ventricle, but don't really focus on these portions. All you need to focus on is the aortic valve.
Exactly, Thomas. Here is the best way to measure the gradient, the best view to measure the gradient, and we have some alternative possibility for the colleagues that are not in the position to take very fast this view. And this is the transgastric long axis view. Let's see it.
Please, Bruno, show us.
Okay. So, starting from transgastric mid-papillary short axis view, we can change our angle from 0 degrees to 90 degrees. This image, the name of this image is transgastric 2-chamber view, like in mid-esophageal. And when we go further to 120 or 130 degrees, we will see on the right side of our image the aortic valve. Here it's very nice to measure a gradient, but take care.
Yes, you have to take care because the orientation here now is not as optimal as we had it from the deep transgastric view, but sometimes this will actually give you higher gradients, especially in a situation where the jet is very eccentric. So this is the way to go, and I think you agree we probably would need to do both to be certain we have the maximal gradient.
Exactly. Take always both if it is possible, and the maximal gradient is the right one.
Right, so as a take-home message, yes, we can quantify aortic stenosis with TE. We can even use it to assess prosthetic valve function. If we want to look at the gradients of an aortic valve prosthesis, it can be done. Of course, you will need a lot of practice, but I can guarantee you, if you practice it often enough, you will be in a situation that you know how to do it if a patient comes along where you have to do it.
The deep transgastric view to look for aortic velocities can also be used in patients who have prosthetic valves and where you're looking for some form of prosthetic dysfunction, as in this example. You see, it looks almost like a 4 or actually 5-chamber view. You've got the tip of the ventricle here at the tip of the transducer, and we're imaging now from the apex down towards the prosthetic valve, and we can simply quantify the degree of obstruction if one would be present with the help of continuous wave Doppler. So this completes the views that we wanted to show you. Of course, there are many more views or variations of these views as a matter of fact. But I believe if you know these, you can probably diagnose, I would say, 90% of the pathologies you need to find. But we're not done yet. We have an additional chapter for you where you'll be able to see a lot of pathologies.